aphakia and amblyopia. What's aphakia? Aphakia means absence of the lens. So the natural lens in the eye is not present. It is not present. Either it is absent congenitally or it is removed surgically. It is removed surgically. There are three terms. One is aphakia, other is pseudophakia, and other is phakia. Aphakia means what? Aphakia means presence of the lens, natural lens. Presence of the natural lens. Aphakia means absence, and pseudophakia means artificial lens. So pseudophakia, then you put the artificial lens, that's called pseudophakia. So once we remove the lens from the eye, what will happen? Because refractive power of the eye has two components, just two components. One is cornea and other is lens. One is cornea, other is lens. So cornea, suppose it follows 45 diopters. Okay? The lens forms 18 diopters or 19 diopters to the refractive power of the eye. So this 18, 19 diopters is lost. Normally it puts the eye in a hypermetropic state. It puts the eye in a hypermetropic state. What's hypermetropic state? Hypermetropic state is parallel rays of light. They come from a distance. They are converged behind the retina. They are converged behind the retina. They are converged behind the retina. Once they are converged behind the retina, so image look blurred. So if they are converged in front of the retina, it's a myopia. It's a so if they are converged behind the retina, it's a hypermetropic. You have pencil, if you have pencil here or some writing. So it puts the eye in a hypermetropic. Parallel rays of light, they are converged in front of the retina. So, they are projected behind the retina. So in order to project them on the retina, what we need to do? We need to put a convex glass. Okay? But the power of the convex glass is very high. It is very high. It's around 10 diopters. How much? 10 diopters. Plus 10. Normal. It can be less or more, but normally in the normal eye it is around plus 10 diopters. So here this is a eye. This is eye. Okay? This is normal eye. This is normal eye. Here the parallel rays of light. This is lens here. It will converge straight on the macula. Okay? Or foveal rays. On the fovea or macula. So this is normal. This is normal pattern. So what happens in hypermetropia or hypermetropia where there is absence of lens? What will happen in that? There is no lens. So it will go to the cornea and it will not be bent because lens is convex, biconvex. It bends the light and puts it on the retina. So there is no biconvexity here. So it will project it behind the retina. Okay? So in order to correct this, now what we do? We put a strong lens in front of the eye, in front of the cornea, in front of the cornea, like this. So it will bend rays first, it will go like this. Okay, then cornea again bend it and it will bring it to focus on the retina. Is it correct? How we can write it?
With the pencil.
Is it? Like this? Okay. So this was about the convex glasses. Okay. So what is the other treatment of it? What is the problem with these convex glasses? What is the problem with these convex glasses? No. What is the practical problems? First of all, they cause a high image magnification. They cause that called image magnification. How I can first? So first is magnification. Okay? Image magnification. So that they cause the image in the objects look much bigger. Okay? So how much magnification is it? 30%, 40% more. Okay? So there is a high image magnification. The images which are formed on the eye, they are much bigger than actual. So this is table, it will be bigger. Okay? This is the first problem with these glasses. These are called aphakic glasses. They are called aphakic glasses. Plus 10. This is one problem. Other problem is number second. That's called pin cushion effect. What's that called?
Pin cushion.
Pin cushion effect. What's pin cushion effect? Pin cushion effect is, suppose it's like this. So it will appear like this. Okay? Straight lines will appear inward like this. This is called pin cushion effect. Why it happens? Because in the peripheral part of the lens there is a prismatic effect. Is it? Prismatic effect. So this is such a problem. Okay. Number third is that's called jack-in-box phenomenon. That's called jack-in-box phenomenon. What's jack-in-box phenomenon? Suppose they are in the central field. This object they are not able to see because of prismatic effect. This is absent field. They are not able to see. Once you turn the eye like this, they will see it. Okay? Suppose this part of the glass, peripheral, it is much thicker. It's much thicker. So it has a prismatic effect. Is it? So they are not able to see this. They are not able to see. This person or this object is absent here. And once they will turn to straight, it will appear. This is called jack-in-box phenomenon. Or this is called jack-in-box phenomenon. Appearance and disappearance of the object. Appearance, first there is disappearance, then there is appearance. So this is called jack-in-box phenomenon. There is one more phenomenon that is called ring scotoma. That's called ring scotoma. Ring scotoma means that once you are looking this, central field is okay. Central field is okay, but around this is a blind area. Scotoma means absence of rigid stimulus, which can be absolute or relative. Relative means it can be reversed. Absolute means it's permanent. So because of the glass, because of the prismatic effect, there is a circular area. Okay, suppose they will turn this ring will come here, opposite field of vision. Suppose they will turn here, this will come like this, on this side. This is called ring scotoma. So these are the problems with these aphakic glasses. Now what is the solution to this? The solution is to put some sort of lens in the eye. To put some sort of lens in the eye. What sort of lens we can put in the eye? Why person remains aphakic during surgery? There is some problem. There is some problem during surgery. There is some complication during surgery. Like the posterior capsule is ruptured. Posterior capsule is ruptured. Or the anterior capsule and posterior capsule, they are removed. They are removed. So once the posterior capsule ruptured and there is no anterior capsule also of the lens available for fixation, then this eye becomes aphakic. This eye becomes aphakic. Because you will put a lens, but only it will support. There is no support for this. The posterior capsule acts as a support. If now posterior capsule is ruptured, there is a CCC, there is the anterior capsule, you can put on that what's called sulcus fixation between the anterior capsule and the iris. But if there is no posterior capsule, no anterior capsule, then lens cannot remain stable. Lens cannot remain stable. So what is the solution? That's what leads to aphakia. That's what leads to aphakia. What is the solution to this? Solution is there are other methods of intraocular lens fixation. One of them is what? One of them is anterior chamber iris. Anterior chamber iris. The lens we put here is in the anterior chamber. It's on the iris. It's on the iris. It is not stitched to iris. It is not attached to iris. Just it is above the iris. These are called anterior chamber iris. Here the iris acts as support. Iris acts as a support. But these have some problems. These have some problems. Those problems are called UGH. UGH, right? UGH syndrome. What's called? UGH syndrome. What's that called? UGH syndrome. What's UGH syndrome? Because they are on the iris, it will cause uveitis. It will cause uveitis. They are on the iris. Once the pigment dispersion occurs, that will obstruct the trabecular meshwork. That's called glaucoma. And H is H because they can irritate the blood vessels of the iris. That can lead to high fever. So these are the three complications of anterior chamber iris: uveitis, glaucoma, and high fever. Because of these three complications, they have gone into disrepute. Now what are the other options? So one more option we have that's called iris supported lens. They are called iris claw lens. They are called iris claw lens. What are iris claw lens? They have a central optic. Then they have like this. Here they have claw, like this. They have claw. So there are two types of iris claw lenses. These claws, in between these two claws, are inserted the iris. The iris is inserted. So iris acts as support by these two claws. So now they can be placed in front of iris, or they can be placed behind the iris. Okay? They can be placed in front of the iris, or they can be placed behind the iris. If they are placed in front of the iris, with iris attached or two claws on two sides, is called anterior iris claw. So if now the iris, they are taken below the iris, and iris is inserted behind the iris. Okay, this is called posterior iris curve. This is called posterior iris curve, or this is called retrofixation. This is called retrofixation, not entrofixation. This is called retrofixation. So anteriorly and posteriorly. So anterior and posterior. So anterior to the iris, posterior to the iris. So anterior to the iris is anterior fixation. Posterior to iris is retrofixation. That's called retrofixation. You understand it? What I've done? So these two, anterior chamber iron and iris lenses. One more problem I forgot to tell you about the ACL. I told you it causes UGA syndrome. In addition to that, because it is close to the cornea, it can cause endothelial decompensation. More a lens is forward or towards the cornea, more endothelial damage it causes. So one of the problems of anterior chamber iron is endothelial decompensation. And this is one more reason why we can go on disfigurement. Endothelial loss is more. Okay? So UGA syndrome and more endothelial loss. And because of those things, the anterior chamber iron they have gone into disfigurement. The iris club, it is practiced nowadays and it can be used. Anterior, more than anterior, posterior is preferred. Posterior is preferred nowadays. Why? Because it's away from the cornea. It's almost a natural position of the lens. So it will cause less endothelial loss theoretically. Practically, whether it does or not, but theoretically it causes less endothelial loss. That's why people are now doing retrofixated iris lenses. So this is one more option for aphakia. Then the third we have that's called signal fixated lens. They are signal fixated lens. What is signal fixated lens? We just take suture from pars plana, 2 mm behind the lens, 2 sutures. Okay? Then we tie 2 loops of the lens in that, on this, and then we tie on the signal. Okay? Like this. Suppose this cornea. Iris I will not make. Suppose this is lens which is behind the iris. It is behind the iris. And this is one loop and this is the other loop. So once we pass suture, we tuck it like this. We pass suture, we will tuck this. So we knot it here, on the signal. Not open signal, we make a pocket there. We make a pocket there, so we bury the knot. We bury it because knot should not be exposed. Knot should not be exposed. So we give a small incision in the signal, or we make a triangular flap or whatever, then we bury the knot. So this is how the iron is held in that place. This is one more technique. There are other techniques also. One is called glued iron. What's called glued iron? What they put in that? They put the haptics. They make tunnels in the signal. They make what's called glued iron. Just I will show you. Glued iron. In that, what they do? Suppose it's cornea, and this is the lens. This is the lens behind the iris, and this is this. So they will push this loop, this haptic within the signal, and they will pull this haptic within the signal. Did you understand this? No, you did not understand this. Because they form a tunnel in the signal. Okay, they form it, by needle they form it, 26 called needle they form a tunnel. And in that tunnel they fix it. Small tunnels. Okay, so it does not need any suture. Then they put a glue and close it. So they will make a rectangular flap here, like this, partial thickness similar, a rectangular flap here, partial thickness. जब आपने दो सेक्शन flap बनाए, then once you pass the loops outside the signal, then you will tuck it within this. You will make a tunnel here by 26 millimeter. You will tuck this loop, and once you pass the needle from here, you will tuck this loop into the signal tunnel. The circular panel is made by 26 gauge needle. That is made in it, so it does not rotate sweetly. It does not rotate sweetly. So this is called glued iron. This is called one of the circular fixated iron. Then one more technique is that's called Yamani technique. What is that called? Yamani technique. What they do in that? They pull these haptics out. Once they pull these haptics out, they just burn the tip with heat pot, and they make it black. They make it black, and that black goes into the signal. That with that black, the iron is hung in the eye. So that's one more technique. I'll just show you how to do. Just to give you an idea. Suppose this cornea, the loop is out here. This is a lens behind the iris, and the loop is out. So what they will do here? They will make a bulb here. Here one more. Once this loop will go back, the circular will not allow it to go into the eye. Because they are normally we have two types of eye. One is called single piece. The material in optic and haptic is same. That's either polymer acrylic or some other material, acrylic or anything. Even silicone based lenses. We have different lenses. But some are three piece. The haptics are of different color and optic is different. Okay, so haptics are generally like polypropylene. They are bluish. They are bluish. So once they are bluish, they are three-piece lenses, and you just burn the tip of that haptic, and that is put in the circular, and this is called Yamani technique. This is called Yamani technique. What they do in that Yamani technique? Just they take 26 needle from here, fix the haptic in that needle, bring it out. Once the needle, another haptic in polypropylene haptic, bring it out. And once they are out, burn the tips with the heat counting, not burn or a black type or some bulb type of thing. Once the bulb, then they take it deep into the signal. So that's not exposed, that's below the conjunctiva. That's below the conjunctiva. That two blacks keep the lens stable in the eye. This is called Yamani technique. So I have told you 5 techniques. Anterior chamber iron, the iris lens, the circular fixated lens, then the glued iron, then the Yamani technique. So these are the 5 standard techniques. Out of this, all are practiced except the anterior chamber. Except it, that is not used. Some people do it still, but they have gone into this too. Because of the UGA syndrome, because of the more endothelial loss. Okay? So these were the surgical techniques to correct aphakia. First I have told you this spectral lenses. Now I have told you this. Any other technique we can correct? We can put contact lenses. We can put plus 10 contact lenses on the cornea. That will correct aphakia. So that's one more form of modality of it. Any other technique? So before this you can write, before this, one is the spectral, that's the aphakic glasses. Number second is the contact lenses. Number third is the contact lenses. Contact lenses. What is the advantage of contact lenses or spectral? They have less magnification. They have, you understand? They have less, they have 5 to 7%. How much? 5 to 7%. Intraocular lens is lesser than that. That's just 1 or 2%. That is the difference. Okay. So contact lenses, those all ring scotoma, that gigantic box phenomenon, pin pushing effect will not be there. Okay. So, any other form of treatment? So, I have told you first aphakic glasses. Second, I have told you contact lenses. And third, I have told you the different types of lenses based on anterior chamber, iris cloud, sclerotrophic Yamani, or blue line. Okay. Any other? Yes. The photorefractive therapy. Refractive correction. Refractive correction. What is refractive correction? We put some tissue on the cornea. We put some tissue on the cornea that increases its refractive power. I think that's called epikeratophobia. What's called epikeratophobia? We put some tissue on the cornea, a corneal tissue, which increases the corneal curvature, and that will lead to a correction of the aphakia. This is called a refractive procedure for aphakic correction. So next, I think it's enough for you for the aphakia. I have to go to one more topic. I have to talk deal. I have amblyopia to talk about. I am sorry, but I have to talk about amblyopia because there are two topics. How about this? You understood nicely? Aphakia? Aphakia you understood? Yes. Aphakia you understood? Yes. Okay. Now I will go to the amblyopia. I will go to the amblyopia. Anybody will tell me what's amblyopia? Amblyopia is a decrease in vision. Is it? Decrease in vision in form or whatever, deprivation, whatever, in which the eye examination is normal and the neuronal examination is normal. And I mean to say, eye is normal, cornea is normal, anterior segment is normal, fundus is normal, okay, the neuronal connections are normal, brain is normal, so typically patient is a decrease in vision. This is called amblyopia. Okay? Other name for amblyopia is what? That's lazy eye. What is? Lazy eye. What is the cause of this amblyopia? Eye is normal. Okay. The brain is normal. 1% is decreasing. It has different types. It has different types. Most important type is refractive. Most important type is refractive errors. What is refractive errors? In that refractive errors, we have three types of almost refractive errors. This is one term in ophthalmology that's called anisometropy. That's called anisometropy or anisometropic amblyopia or anisometropic amblyopia. What's an isometropic amblyopia? An isometropic amblyopia is, suppose right eye has a -4 and left eye is normal. Left eye is 6 vision, right eye has county figure and with -4 refractive error in the right eye. So one eye has error, other eye does not have error. So this is an isometropy. And this is disparity between the two eyes. There is a disparity between the two eyes. This is called an isometropic amblyopia. Suppose I have -4 in the right and left eye have 6 vision. Now what will happen? I will see the left eye. I and ignore the right eye. Brain will ignore the right eye and it becomes lazy. You understand? So you can't see, your vision in the right eye gets blurred with time. Okay? So suppose left has now 6:6, right has suppose 6:18 or 6:24 or 6:36. Refraction comes -4 in the right. Once we put -4 in the right, it doesn't improve. And once we check the fundus, it's normal. Once we check the pupillary reflexes or the brain, it's normal, even by neural imaging. Okay, this is called anisometropic amblyopia. Then we have other is called refractive amblyopia. What's called? Refractive amblyopia. Refractive amblyopia, somebody has high hypermetropia, like +6, +7, +8, +10. Okay, and somebody has high myopia, -6, -8, -10. They are prone to develop amblyopia. When they will not get us. Some people, some child, he develops myopia in the child, or he has hypermetropia by birth, and parents are reluctant to wear glasses. Okay, they tell, no, why should we put glasses on the child? He's 2 years old. You understand? He's a 1 year old. And patient, child does not see clearly, and with time he develops amblyopia. Even if you now give attention to at 8 or 7 or this, the vision will not improve. Despite fundus and neuronal examination is no. This is called refractive amblyopia. So anything above -6, and anything above, I think +6 or +8, whatever you want. Okay, that can cause refractive amblyopia. That is called refractive amblyopia. So I have only 2 things. One anisometropic amblyopia, in which one eye is normal, other has a refractive eye. Second is refractive amblyopia, in which both eyes have refractive eye, but they are of higher order. They are like above +4 or above +5, and above -6 or above -7, like that. This is called refractive amblyopia. And remember, refractive errors are second cause of blindness. They are second cause of blindness. First is cataract, and second cause of blindness is refractive error because of this, because of the amblyopia. If somebody asks you what is the number 1 cause of blindness, tell cataract. And number 2, somebody will ask, tell refractive. And so, because it's such a big percentage of blindness, it's a main public problem. Community has problem. Okay, community eye problem. Because refractive errors are second to cataract for blindness. And because of those things, and with the illiterate population, with the underdeveloped population who are not ready to wear glasses, this can lead to this. So as a medical professional, as a healthcare professional, it's your responsibility to make public aware, even at home or even in benefit, about these things, so that this child, he does not have developed amblyopia, and he does not lose vision because of non-wearing of spectacles. Just a pair of spectacles, which costs hardly 500, 1,000, 2,000 rupees. Then this was about the refractiveness. Then we have one more amblyopia that's called stimulus deprivation. What's called? Stimulus deprivation amblyopia. What's called? Stimulus deprivation amblyopia. What's stimulus deprivation amblyopia? Child is born with natural cataract. Child is born with natural cataract. He is not seeing. So if this cataract is removed, he will develop a normal vision. This is stimulus deprivation. The light does not reach the retina. This happens in what? In congenital cataract. It happens in congenital cataract. It happens in congenital cataract. This is called stimulus deprivation amblyopia. This is called stimulus deprivation, amblyopia. So we have anisometropic amblyopia, we have refractive amblyopia, we have stimulus deprivation amblyopia. Okay, there will be some other cause of amblyopia also. One of the causes of amblyopia is patching. If you patch the eye, it will have amblyopia. That's called patch amblyopia. That's called patch amblyopia. Because of patch, if eye is closed, there is one more amblyopia that is called totally meridional. What's called? Meridional amblyopia. What's called? Meridional. You read about that. I think meridional is related to astigmatism. It's related to astigmatism. And in one of the malignant, patient is not seeing clearly, and that can lead to amblyopia. That can lead to amblyopia. So how to diagnose it? Diagnose. First of all, I told you this is refractive error in the eye or this is a cataract, and patient is not employing the correction we are doing. Okay? Once we check this examination, eye examination or neural examination, that's normal. But the whole rule of the thumb is between the two eyes there should be 2 lines difference. How much? 2 lines. That means if one has 6'6", other has 6'24", this is 2 lines difference. Because 636, 660, like that. Yeah, or you can say like not 6'24". If one has 6'6", other should have 6'18". 6'18 के बाद आता है 6'12", then 6'9", and then 6'6". So 6'9", 6'12", 6'12", 6'9", 6'6", or 6'18". So 2 lines difference between the 2 eyes. If one is 6'6", other is 6'12", it becomes a 2 line difference. Okay. So once we have 2 lines of difference with eye examination normal and neuronal examination normal, it fits into the case of amblyopia. Okay. So that's first thing. The other thing I told you, the fundus examination and the neuronal examination is normal. Okay. Then we have some other tests. You can read about them. One is called neutral density filter test. What's called? Neutral density filter test. Neutral density filter test. Then one more we have is how to treat now. Now I come to the treatment. What's treatment for amblyopia? If there is refractive error, give spectacles. Give spectacles first. And after spectacles, you will give patches. You will give patches. You will give patches. I will explain the patches. Third is, if there is suppose stimulus deprivation. There is stimulus deprivation. That is called, the way I told you, congenital cataract. So you do the Now you have to remove this cataract and it will reverse the stimulus deprivation. So light will fall onto the retina and it will develop problem. Okay? It will correct. One more I forgot to tell you, I told you the types: anisometropic, refractive, then meridional, then this patch, amblyopia. One more you write here is strabismic amblyopia. Stimulus deprivation is strabismic. Strabismic amblyopia means patient has sitting. Patient has sitting. Convergent sitting or divergent sitting. Convergent sitting or divergent sitting. So you have to correct the sitting. You have to correct the sitting. So treatment, if I go by the treatment, first will be suppose spectral. Spectral for what? For refractive. Well, there is high myopia, there is hypermetropia, there is meridional, or there is anisometropia. Okay? So refractive, spectral. If now stimulus deprivation, then you do cataract surgery. Then you do cataract surgery or stimulus deprivation. Stimulus deprivation is not only cataract. Generally, it is cataract, conjunctival cataract. So somebody has said you corneoplasty. That will also come in this stimulus deprivation, because that will not allow the light to fall on the retina, and that is a corneal transplant or whatever. Something has to be done to the cornea. So that's one more cause of stimulus deprivation. Whether you have a problem in the cornea, whether you have a problem in the anterior chamber, or you have a problem in the lens. That's not allowing in a child to fall the natural light onto the retina. And retina is not developed. Macula is not developed. It is one more phenomenon in that. If you delay this by 2 or 3 months or 4 months, generally parents do, then the child develops in searching status. He develops, that's a bad prognostic sign. That's it. So the congenital cataract should be operated at the earliest. That should be operated at the earliest. Suppose child is born with a macular cataract, we have to tell him to get him operated. There is no chance of waiting. There is no logic of waiting. Then he will develop a surging nystagmus, and that's a bad prognostic sign. Then you need to put the lens, you remove the cataract, you put the lens, patient will not recognize. If before the nystagmus, you operate, you put the lens, generally some people put later lens also after 1 year, that's a different thing, but cataract has to be removed. Okay? Whether you put lens at that moment or later, but the cataract has to be removed, and if you put remove the cataract before searching nystagmus, it has a good prognosis. It has a good prognosis. But once the nystagmus is searching nystagmus develops, then it has a bad prognosis. It has a as a medical professional, your responsibility was to see that child. You have to tell him, get him operated right now. Don't waste your time, because it is a question of child's life, his vision for the life test of his life. If it's affected, nothing can be done. So spectrums, then the cataract surgery, then third. If suppose there is strabismus, there is sitting. You do a sitting correction. You do a sitting correction. Okay. So these are the 3 forms of treatment in this. In addition, suppose we have now given, suppose the way I told you, right hand is -4, left is 6, 6. Now we have given -4 in the right hand, left hand we have given plain, whatever. Now with -4, he has still blurred, because what qualifies it for the diagnosis of amblyopia? You understand what we do? We will patch the side. We will patch normal. We will patch the normal. Once we patch the normal eye, child will more use the right eye, and it will recover. This is patch. Okay? But patching has to be given after we give the steps, not without steps. Okay? This is the rule of thumb. There is the rule of the thumb. Rule of thumb is if child is 2 years, if child is 2 years, you do 2-day patching. How many? 2 days. Suppose patient has 3 years, you do 3-day patching. Okay? Once it is 4 years, you do 4-day patching. If it is 5 years, you do 5-day patching. Like that. Why it is so? Can anyone explain this? More longer amblyopia means in the person, longer it will take to reverse it. Okay? At 2 years, only 2 days needed. At 3 years, 3 days needed. Okay? At 4 days, 4 days. What we do in this? We give suppose right eye has amblyopia. We give patch for 4 days or 3 days. Then we give 1 day in this eye also. Why? Because this eye can develop amblyopia. Normal eye can develop amblyopia. That's what I told you, patch amblyopia. You understand? So we have to patch normal also for 1 day. And 1 day we have to keep both eyes open. 1 day we have to keep both eyes open. And once the vision becomes same in the both eyes, suppose there is 660 vision in both eyes, and patient uses -6 in both eyes. Okay, kitna? -6. Once the patient, suppose once the vision becomes equal in both eyes, 6-9, 6-9, 6-12, 6-12, then you give alternate. Right eye 1 day, left eye 1 day. Okay, again right eye, left eye. Okay, so it's called alternate patch. It's called alternate patch. Generally, the problem with this patching is these parents are very reluctant to use it. Why? Because they tell how they can go to school with patching. But technically there is no problem. That's not an issue. You understand? And we give 2 types of patching. One is called full-time patch. What's called? That's from 9 till 5 or 6. 9 till 5 or 6. So that includes the day. That includes the school day. And other is called partial. Other is called partial patch. That is done, suppose after 4. Suppose somebody is reluctant to use it during the day, we can advise him to do it after 4, up to 10, 6 hours. Okay? That's called partial patch. So we have full time patching, we have partial patch. So we have 2 types of patching. And is there any alternative to patching? Yes, there is an alternative. Alternative to patching is we put metallic in one. So suppose the eye which is normal, we put metallic in that. We will put cyclopentone or atropine. Once we put that, it becomes blurred. It becomes blurred. Once it becomes blurred, they will use that. Okay? This is called what? There is a term for this. Is it? What is this term? Anybody can tell me? It's called penalization. It's called penalization. It's called penalization. Penalization. We could put atropine or cyclopentone. Atropine 1% used as ointment. As in ointment. In children we do give drops atropine. Why? It can cause systemic toxicity. It can cause systemic toxicity. So we do ointment. And cyclopentone comes in 2% eye drops, which can be used twice a day. So above 2 years you can use 2%. If below 2 years you can put 1%. Less than 2 years, 1%. This is called penalization. This is called penalization. Any other form of treatment? one drug has been approved. One drug has been approved. Can you guess which will be the drug? You have read medicine or not? Medicine you have read or not? What's the problem in amblyopia? Why is the problem? Eyes normal, brain is normal, why is the problem? It is at the level of neurotransmitters, at synapse. Okay? Where? At the synapse level, at the neurotransmission level. At the synapse level, at the neurotransmission release. You understand? So one drug has been given that's called levodopa. That has been approved for amblyopia. That's been approved for amblyopia. So that you remember this drug. This is called levodopa. That fusion, I think, Parkinson's disease also. Huh? So levodopa is the tablet. Levodopa can be used. Then one more, some people give some sort of a stimulus to the retina, red light or laser sort of photopic stimulation. That's called photopic stimulation of the retina, so that the vision is stimulated, neurotransmitter release is increased. Most important thing, this is the last point I will have in this class, is that once you give patching, you have to tell the parents that now overuse the other eye. Suppose left eye was normal, I have patched this eye of the child. Now right eye is very mindful. He is very mindful. Now tell him to put different beats like red, yellow, try to separate or play video games, so that this eye is doing some more work and the reversal will be more. Okay. One more point came to my mind is generally amblyopia was previously considered to be reversible by 10 years only. Why? So about 10 years, people were saying there is no fun of doing patching. But the present knowledge and the present recommendation is